Well, friends, I am Dr. V.K. Malik, and I am currently the Dean of Academics at Sir Ganga Ram Hospital. Before that, I was a Professor of Surgery at Maulana Azad Medical College and have had a great deal of interest in academics. I've been doing these sessions earlier on before the COVID, but after COVID, my involvement in my work increased, and therefore I was not able to take that active participation in these meetings. Hopefully, in the times to come, we will be doing these sessions more frequently. So today's topic is not benign lesions of esophagus, but is benign tumors of esophagus. And it is indeed a very, very small topic, and that's what I was telling Ms. Mukta, that this topic is very small, and probably, its importance lies in the fact that it helps us understand a few things about esophagus. It is not very important in the sense that the entity is very common or entity is very symptomatic. So, by and large, sometimes it's a matter of curiosity that one comes across these rare lesions. So, let's get going on this subject. So, as we all know, the first thing first, we have to be quite clear about the anatomy of the esophagus. The histological anatomy of esophagus, starting from inside, you have epithelium, then you have the basement membrane, the lamina propria, the muscularis, and then you have the submucosa, and then you have muscularis propria. The muscularis propria and is mostly a longitudinally aligned muscle. The main strength of esophagus lies in the layer called submucosa. And all these layers are so well identified on the ultrasound, endoscopic ultrasound. And that's why endoscopic ultrasound is now becoming a standard of evaluating the esophageal lesions in a big way. In setups where endoscopic ultrasound is available, this is something which helps us identify the site of origin of lesion, and also if it's a infiltrative lesion, to find out how deeply it is infiltrating. So it's not only a simply tool to diagnose, but can also help us in staging the lesion with respect to carcinoma of the esophagus. So I think this bears remembering that epithelium, basement membrane, lamina propria, then muscularis mucosae, submucosa, and muscularis propria. The lesions which are occurring um, from the epithelium to the submucosa generally protrude within the lumen of the bowel, whereas the lesions which are occurring in the muscularis are present, which push the mucosa inside and present as some kind of a filling defect. So we will be using these words intraluminal for these entities which cause lesion in the epithelium, basement membrane, lamina propria, muscularis mucosae, and submucosa, and the ones which are giving rise to some lesions or tumor formations in the muscularis are referred to as intramural. So intraluminal and intramural. Then of course the outer layer is a periesophageal tissue. And as we all know, esophagus doesn't have any serosa. Now, as I was telling, ultrasound has become a very important tool in identifying from where the lesion is arising, and also for finding out, in case of infiltrative lesions, up to what level the lesion is infiltrating. First layer is hyperechoic, and that's the interface between the balloon and the superficial mucosa. Then the second layer is hypoechoic, that is the lamina propria and the muscularis mucosae. Third layer is hyperechoic again, and that is submucosa. Fourth layer is hypoechoic again, and this is muscularis propria. And fifth layer is hyperechoic, and that's the interface between the adventitia and the surrounding tissues. So by endoscopic ultrasound, one can find out the site of origin of the lesion, and also in case of infiltrative lesions, the extent of infiltration into the periphery, into the adventitia. Now, what are the various benign lesions of esophagus? The mucosa, as we have identified, mucosa would be epithelium, lamina propria, and then, of course, submucosa, which is a well-defined entity, and muscularis or muscularis propria. So the lesions arising from the esophagus are the mucosal lesions arising from the mucosa. These could be granular cell tumors, quite uncommon. Generally, the Schwann cell is supposed to be the offending cell of origin. Fibrovascular polyps, like anywhere else, the polyps can appear in any mucosal surface, and these are very innocuous type of polyps which may be present in the lumen, and they are very rarely symptomatic. Squamous cell papillomas are also present, and these are flat lesions which may have sometimes some degree of uh, so some degree of commonality with the HPV virus. And these lesions again are flat lesions, generally do not cause symptoms, and would be generally picked up on endoscopy. Endoscopy is generally the tool, by which we generally find these lesions. And when uh, patient is undergoing endoscopy for any unrelated problem, and you pick up these lesions, these would be the lesions of some curiosity. Otherwise, they do not have much significance of their own. In case they are symptomatic, and I think we can address the issues here itself, they would be picked up on a routine endoscopy, and mostly they will be asymptomatic. But in case they are symptomatic, or in case that curiosity needs to be resolved by way of giving a proper diagnosis, then you endoscopically all these lesions can be managed unless they are too extensive. So by endoscopic snaring of these papillomatous lesions, most of these most of these lesions arising from the mucosal surface can be addressed. Now, in the submucosal lesion, in the category of submucosal lesions, we have lipomas, hemangiomas, neurofibromas, and schwannomas. So these are the ones, like lipomas occurring anywhere else. Like we know that lipomas can also occur in the ileum and jejunum. Anywhere, wherever there is adipose tissue, lipoma can appear. Similarly, hemangiomas, hematomas seen anywhere across the body, and uh, esophagus is not immune from having hemangiomas. Similarly, neurofibromas, they are of course not so common. Schwannomas can also be seen, but again, these lesions are quite uncommon. Mostly they are asymptomatic, and when symptomatic, can be endoscopically removed. The most interesting lesion in this category would be the lesion arising from the muscularis or what is called as muscularis propria. These are leiomyomas, gist, and leiomyosarcomas. Now, these are the lesions which can arise from the muscularis or the muscularis propria. Leiomyomas and GIST are two different tumors, and they can be categorized on the basis of molecular markers. And I'm sure GIST must have been discussed with you in greater details. So I don't need to pick up those various molecular markers which are seen on the GIST. But suffice it to say that GIST is less common in the esophagus than it is elsewhere in the gastrointestinal tract. And leiomyosarcoma, of course, these are the leiomyomas which at times, and this would be, of course, a very rare transformation of a leiomyoma to become a leiomyosarcoma. And so this is the kind of these are gamut of cases, these are gamut of situations that you see arising from the muscularis propria, and these lesions generally would be on one circumference